Good afternoon, everyone, and welcome to the fifth workshop in our series on transforming health services in line with the government and NHS priorities. And before we start, I would like to introduce ourselves. So we are Unity Insights, a social enterprise embedded in the NHS, having historically been part of the Health Innovation Network. So we have a vast experience of working with healthcare professionals, innovators, commissioners, providers to support with NHS-specific challenges. And just to say a little bit more about the speakers, I will kick us off. So my name is Léa Quentin, and I'm a lead analyst at Unity Insights. A lot of my work focuses on leading real-world evaluation, using mixed method approach, health economics modeling, as well as a health inequality assessment. And I will now pass on to Ben.
Thank you, Léa. Afternoon, everyone. I'm Ben Williams. I've worked in healthcare analytics for over 18 years, analysing and visualising data with an interest in improving data literacy. Currently, I lead evaluations across a range of new technologies and pathway change programmes. And with that, I will pass on to Faye.
Thanks, Ben. My name is Faye Maddock. I'm a senior analyst at Unity Insights. I've been with the team for just over 3 years now, and whilst being part of the team, I've used various analytical techniques in a wide range of projects spanning from evaluating apps to radiotherapy treatments for cancer.
And just to say a little bit about our experience and our expertise in the domain. So we have over 5 years of experience performing and conducting health inequality analysis, really looking to pioneer approach, as well as working with different partners to address data challenges. We have supported innovators and commissioners looking to embed and tackle health inequality. It is also part of our core mission to do what we can to drive social good and really use our expertise to ensure equitable access to care, using our expertise in evaluation to really bring that out. And we also were able to provide the measurement and evaluation guidance for the first National Health Inequality Programme, which was launched 2 years ago. So overall, we have conducted over 15 health inequality focused projects, but those were probably quite extraordinary. But in terms of health inequality assessment, this is something that we embed in all our evaluation projects. And so today's focus is really on looking at reducing healthcare inequalities. And today together, we will go through a little bit of an overview of the challenges, as well as the solution and ambition of the government and the NHS to alleviate the issue. We will then talk about what we mean by health inequality, how do we demonstrate impact, looking at a couple of case studies. And then finally, we will share some learnings and key takeaways. And we will keep some time at the end, hopefully, for the Q&A session. So please use the Q&A function if you want to ask any question throughout the presentation. So first, let's start by going over the challenges faced and the ambition set out by the government and the NHS. So there is a wealth of evidence showing that some groups of people experience significantly poor health and significantly worse experience of health and care services than others. This is a long-standing injustice, and this has been made worse by the COVID-19 pandemic and more recently by the cost of living crisis. And these differences in health experience and outcome are avoidable, they are unfair, and they are systematic. And yet we can see that they continue to widen. And to take a few examples, so here are some stark figures on the impact of this inequality on health outcome. So for example, on life expectancy and how this vary widely across communities. And this is in line with the priorities of the government as they are looking to halve the gap in health expectancy, especially between different groups on the deprivation scale. Looking at maternity care, the National Maternity and Perinatal Audit shows that whilst overall stillbirth rates are low, rates are higher for baby born to women of South Asian and Black ethnic group when compared to white and other ethnic group. And this is further compounded by deprivation as well. And so if we widen a little bit, obviously, not just maternity, but women's health in general, that's something that's also really key to some of the pledges and some of the priorities highlighted in recent months. And to take a last example related to mental health, we can see in that the graph that's on the screen that there's really a lack of equity when it comes to access to care, with this graph showing a significant difference when it comes to accessing a certain treatment. Here it's NHS talking therapy based on population age, sex, ethnicity, and disability. And so when it comes to tackling these challenges, the NHS have set up a strategic vision. And so they want to have a holistic view of the issue to really try and influence multi-agency action to address the social determinant of health. So think anything that's outside of health, but that influences health status. So that can be education, employment, living situation, environment, and so on and so forth. They also are using the weight as one of the biggest employers to make the right choices and to help moderate inequality when it comes to workplace. And then finally, they are supporting a number of initiatives looking at tackling inequalities in healthcare provision, so really thinking about access, experience, and outcome. And so that strategic vision has in turn set the following objective: to restore services inclusively, to mitigate against digital exclusion, to really look at improving data sets, to have complete and timely data sets, look at prevention, especially accelerating the access to preventative program, and then finally to think about the culture that is needed to drive those improvements through leadership and accountability. And so to show another initiative, so started a few years ago, the Core 20+5 initiative clearly highlights what NHS organizations should consider when looking at reducing health inequality. So the term is actually looking at 3 different elements brought together under one single umbrella term. So Core 20 refers to those in the 20% most deprived areas of the country, plus is anything specific to a population group. And then the 5 are the 5 clinical areas that the NHS is focusing on, with smoking cessation being an additional one that is a cross-cutting theme across all of them. And I will now pass on to my colleague Ben, who will define a few concepts that we will use throughout the workshop and also explain the importance of health inequality analysis.
Thank you, Leah. Excuse me. What are health inequalities? So I'm assuming that most of you are going to be aware of this, but just to sort of go over some of the basics. So the King's Fund define health inequalities as avoidable, unfair and systematic differences in health between different groups of people. Essentially, if you give everyone the same opportunity to access or benefit, this doesn't necessarily mean that everyone will have equal access or an equal share of that benefit. In healthcare, this can be down to ethnicity or gender, or due to an area in which an individual lives. It is important to remember that while a person will identify as having a particular ethnicity or a gender, deprivation is an average measure relating to the people in a geographic area. So what is deprivation? So IMD, or Index of Multiple Deprivation, is exactly what it says. There are 7 separate domains, which we've listed out here. And IMD then creates a composite score across the 7 domains. If you imagine you're walking around a city, you've probably been in a situation where you've crossed a road or gone down a side street and noticed a visible change to the area you're in. Now, many of these 7 domains, they won't be as visible from the outside. So it's important that measurement is done at an appropriate level of detail. Without this, you miss the nuance, as aggregation tends to cause data to move towards the average. So how does deprivation then link to the Core 20+5? So as Leah said, the Core 20 looks at deprivation. The latest IMD datasets from 2019, it consists of 32,844 lower layer super output areas, or LSOAs. So essentially the Core 20 is the 6,500 or so areas which rank as the most deprived. And again, it's important to consider that people live in deprived areas but are not necessarily deprived people. So why is it important to measure? Just something for you to think about: which item on this list best fits your intervention. Regardless, it's important that you remember that your intervention is introducing a change. No matter which one of the items in the group you fit into, you're still introducing a change and you want to measure that change. Now, does your intervention aim to give everyone equal access? Remember that equal access does not provide equity, so it's important to identify where the risks lie around inequalities. More than that, it's important to measure the extent to which you're tackling or potentially embedding health inequalities. Once you've measured this, you can then identify any changes to the methods employed so you can help to tackle the inequalities. So how do you do health inequalities analysis? Well, the best way to think about it is as a cohort analysis. You can apply health inequalities to any analysis you're already planning to undertake by filtering down to the population of interest. There's two main things that you could look at. So firstly is how does the measure in this population compare with the entire intervention group? And then also how does it compare with the underlying population in your intervention geography? Some examples of how you could do this would include, so qualitatively, whether through surveys, interviews or focus groups, you first need to identify if if they are willing within the inequalities group that you're studying, and then ask them about their experience. Remember, you also need to ask those not in the group you're studying to ensure that you can assign factors to this group and that it's not systemic across all the participants. Quantitatively, I touched on this in the previous slide. So here you would filter down to the population of interest and compare the entire intervention group or the underlying population, or both. Now, when considering health inequalities, it's often the case that you're dealing with historically underserved populations. The reasons behind this can be complex, and so serving the population may be more expensive. If you're undertaking health economics, ensure that you not only look at the potentially higher costs, but also whether the benefits of reaching this population may be higher. You might just find out that while it's more expensive, the benefits outweigh the costs. Now, with that said, there are some key elements you need to consider when undertaking health inequalities analysis. So demographics, maybe it goes without saying, but can you get the right level of data, the right level of granularity to reflect your population of interest? Engagement, how will you engage and reach those you're interested in speaking to? Representation, are those that you want to speak to responding? Is there any risk of bias in who is speaking to you? And then finally, PPIE, public and patient involvement and engagement. This is actually two elements together. So involvement is where service users and their families, where appropriate, are actively involved in development and design of programs. Engagement then takes this a step further to become a longer term relationship where outcomes are shared so that service users and the public are informed about the work. Now, this can be an excellent tool for building relationships, testing ideas, and potentially avoiding problems later on. So next, we will look at a couple of examples which highlight in a real-world setting what we've outlined so far and how to demonstrate impact. I will pass over to Faye for our first case study.
Thank you, Ben. So as Ben said, we're going to go over the case studies, and the first case study looks at the Real Birth Workshop. So the Real Birth Workshop is an online workshop consisting of 11 modules focused on elements such as the different stages of labour and how the uterus works during labour. These modules can be completed in the own user's time, and the use of modules allows women to learn in a structured approach. The Real Birth Workshop aims to be accessible through allowing women to select their preferred language and change the background colour and text size, etc. So the aim here is to ensure that as many women as possible have access to birth preparation information. The workshop was implemented in 2 hospitals, in East Kent Hospitals University NHS Foundation Trust, and staff were trained to understand the information that the workshop provided and ensure that they were comfortable with referring mothers to the workshop. We were commissioned by Health Innovation Kent Surrey Sussex and the Real Birth Company to evaluate the impact of the Real Birth Workshop and also the staff training within East Kent Trust. In our evaluation, we compared the ethnicity breakdown from the proportion of antenatal patients in East Kent Trust overall to the proportion of patients who completed the Real Birth Workshop. And this chart here shows the findings. So we can see that the proportions vary between the 2 populations, But what percentage actually counts as a significant difference between the two populations? And what percentage counts as the proportions being the same? Today, we're going to focus on the Black population for our example, where you can see that 1.6% of the trust population are Black and 2.6% of the workshop population are Black. So how do we tell if there is a statistically significant difference between the two? First, I want to break down the proportions within the evaluation. So we first have a population of women in East Kent Trust who had given birth, and within this population, we knew that 1.6% of these women were Black. Separately, the women in East Kent who had given birth population was then split into those who did and did not complete the real birth workshop. Of the women who did complete the real birth workshop, 2.6% were Black. This difference between 1.6% and 2.6% seems small, but how do we know whether there definitely is a meaningful difference or not? What we wanted to do was compare the proportion of Black women who completed the real birth workshop to the overall trust population. And we did this by conducting a statistical test. So when we complete a statistical test, a significant result would suggest that the difference between the two proportions was statistically different, implying that the workshop mitigates health inequalities. Whereas a non-significant result would then suggest that the proportions are very similar, and hence the workshop is representative of the Black population of women in East Kent Trust overall. Comparing small changes in proportions can be quite hard because you want to make sure that you make the right inferences from the data. And the best way to do that in this case is to complete a statistical test. Statistical tests allow for stronger conclusions to be made from health inequalities analysis, and it can allow us to understand if there is a statistically significant difference between the two proportions. An example of this is a binomial test, and we decided to conduct a binomial test because this would help understand whether the proportion of Black women who completed the real birth workshop corresponds to the expected distribution, which in this case is the proportion of Black women in East Kent Trust. We set our significance level at 0.05, meaning that we would only be accepting our alternate hypothesis if there was less than 5% likelihood that the difference was due to chance. When you conduct a binomial statistical test, you get a z-statistic at the end of your output, and the rules around a binomial test mean that we need a z-statistic either greater than 1.96 or less than minus 1.96 for the difference to be statistically significant. When we completed the statistical test, we identified a z-statistic of 2.34. And as the z-statistic is greater than 1.96, there was a statistically significant difference between the percentage of Black women in East Kent Trust overall and the percentage of Black women who completed the real birth workshop. This means that the workshop is more representative of Black women when compared to East Kent Trust overall. And therefore, the real birth workshop is more accessible to Black women and so may mitigate the impact of health inequalities. This case study highlights the importance of statistical testing to understand your population more and generate insightful conclusions. It's always worth conducting statistical tests if you're unsure what conclusions to make from your analysis. I will now pass on to Ben for the second case study.
Thanks, Faye. So this next case study was quite heavily qualitative evaluation and looking to understand the impact of a programme purposely targeting specific populations. So let's start with a little background. Underserved populations, including refugees, domestic abuse victims, homeless populations, housebound people, and Gypsy Roma Traveller (GRT) communities, face various barriers to accessing health and social care. This could include, but is not limited to, health status and priorities, practical and financial issues, discrimination, social stigma, health literacy, and cultural or language barriers. Now, without targeted interventions, the consequences for these underserved populations can be significant. untreated medical conditions could escalate, leading to heightened morbidity and mortality rates. Unmet healthcare needs can contribute to greater burden on NHS resources, including increased emergency department visits and hospital admissions, placing further strain on an already stretched healthcare system. The National Immunisation Pilot, led by East Surrey GP Federation Alliance for Better Care, or ABC, and the ICB's System Vaccinations Operations Centre team, created an outreach programme to engage these underserved communities. Surrey Hartons ICB was selected as a national pilot site for the National Immunisation Strategy, focusing on outreach and reducing health inequalities. ABC targeted underserved cohorts with low COVID-19 vaccination rates, such as the GRT communities, homeless shelters and domestic violence shelters, with the goal of removing barriers associated with accessing care amongst these populations. An earlier phase 1 evaluation demonstrated the programme's success in reaching underserved cohorts and highlighted the importance of building trust within communities. This phase 2 evaluation aimed to generate qualitative evidence regarding how the underserved populations might have behaved without the outreach programme's presence, assessing whether these populations would have sought vaccinations or making every contact count interventions through other means, or benefited from either individual or public health advantages. The evaluation used 6 different data sources, including both qualitative and quantitative data sets. So for this evaluation, we devised 4 evaluation questions, and I'll just take you through both the questions and our findings. So the first evaluation question looked to confirm whether the programme was reaching underserved cohorts. The Index of Multiple Deprivation, IMD decile scores, suggest that the outreach programme successfully targeted populations living in more deprived areas. Additionally, a large proportion of service users were female, aged between 40 and 59 years old, and those who had ethnicity recorded, a large proportion of Survey 1 respondents were of Asian background. Of the Making Every Contact Count patients, over a third were from mixed or multiple ethnic groups, 63% had a BMI classified as overweight or obese, and 34% had elevated cholesterol. So in answering this evaluation questions, our findings show that the populations accessing the service had poorer health statuses and outcomes. Question 2 looked to understand whether the population that accessed the service would have received provision elsewhere had the outreach programme not been available to them. For this, it was important to understand which services patients accessed. So from survey data, it's apparent that most users access the Making Every Contact Count service. When asked whether they would access the service elsewhere, for Survey 1, over 60% of vaccination service users reported not accessing service elsewhere. And this was similar for Survey 2, with both vaccination services and Making Every Contact Count services reporting at 57 and 59% respectively. So these findings suggest that a large proportion of patients would not have accessed healthcare services had the programme not been available. Question 3 looked to explore the barriers to accessing healthcare. Using survey data, we were able to identify the wide range of barriers that underserved cohorts encountered when accessing health services. These included service availability, travel, appointment availability and booking methods, not being invited or offered to attend, preference for alternative settings, and ineligibility. When asked if they would have felt able to book services via 119, 66% said they would not have been able to due to either a lack of knowledge and awareness, language, or digital access and literacy. Moreover, when asked if they were willing to travel to a vaccination centre had the outreach programme not been available, 64% said they were not willing due to financial hardship, ability or want to travel, or lack of knowledge on transport. The answers here tell us that the service availability, appointment booking methods and travel acted as the main barriers to accessing health services. Specifically, it demonstrates that the outreach programme mitigated these barriers by bringing services into the community. The final question looked at whether or not the intervention was seen as beneficial by service users. So a thematic analysis on service feedback indicated extremely positive feedback about the outreach programme. Based on feedback from respondents who received the Making Every Contact Count services, 677 in total, Patients felt extremely positive about the checks offered, as indicated by an average of 86 out of 100 score, with 581 positive comments relating to either the service itself or the staff involved. Users specifically commented on the quality of service, the walk-in approach, and its convenience. Additionally, 57% of respondents felt that other routine checks would have been helpful. Together, these results suggest that underserved cohorts perceive the health checks as beneficial. We shared this case study as it highlights the importance of both a clear measurement framework that answers the most important questions and of embedding health inequalities from the start. It shows how a qualitative approach can be powerful in revealing previously unknown or poorly described information. So now I will hand over to Leah to bring together the different elements we've discussed today.
Thank you, Ben, and thank you for those a very interesting case study. And so now we thought it'd be really interesting to share some of the learnings that we have accumulated through the number of projects that we conduct around health inequality. And so the first one is around the importance of understanding the need and to really be specific in your approach there. So, for example, if we take a given disease or condition, if you're looking at the prevalence in the general population, and you also have a subgroup of interest that is currently not necessarily accessing the care or having the same outcome as the rest of the population, really thinking about their prevalence. And in this example, for example, the population is already twice as likely to suffer from the disease. So when you then design a solution or a new pathway to address that disease or to help treat it, it's important to look at the solution uptake in that specific way as well, to make sure that your population of interest is actually not just having the same uptake as the rest of the population, which would actually mean that there's probably a subset that's not being engaged with, but that is really accounting for the need to start off with, so that you can understand whether you are reducing the gap or whether you are just perpetuating that gap with the new solution. This is also really important to think about the comparators that you're using when you're thinking about the need and understanding it. Another learning that we really want to share is around the approach that will be taken, and really the importance of having a clear research question. And we've seen that with both case studies in terms of really thinking about the purpose of the analysis and what question you want to answer with it. And that's really important because it will mean that the answer that you get will be actionable, insightful, and will also help you to shape what other improvement you need to conduct. Another big element to consider in the approach taken is the data quality. So a number of demographic measures are currently poorly collected, and there's multiple reasons for that. It can be around the collection mechanism, the reporting system, a change in landscape in terms of the typology used, attitudes of patient and staff when it comes to the collection, and so on and so forth. So, it will be important to understand where the barriers are, where the gaps are, and how will you handle that in the evaluation as well, in terms of interpretation. Another important thing to think about when you're thinking about your data is not just the quality, but also any bias that you might have in your data sets, as inequality are often baked in the data as well. And that will be relevant for all your projects, but especially for digital and AI solution, where biases can amplify health inequalities. So really conducting a review of the data before the project start and encouraging the team to improve data quality through the project is important. And then finally on the data, to think also about the data governance, which can be seen as a bias, especially if you are looking to collect population data on quite a small and granular level, but actually it needs to be thought of as a need to have to really have an insightful evaluation or a project. And so really thinking ahead of time, so that it's not seen as a barrier, but really as something that you will go through with the right IGN processes in place. Another learning that's important to think about is the measurement framework. So firstly, really thinking about the sample size that you might need. So if you are looking at a subset of the population, that's quite a small percentage, then you will likely need quite a big sample to start to see any difference, and then an even bigger sample if you want to go beyond descriptive analysis and go into something that's a little bit more like the statistical analysis we went through with the first case study. So that's really something to think about in terms of what you will know as an answer from the start based on your population and its size. The other thing to think about is really to consider what cannot be measured, as not every characteristic that might be of interest might be documented in your project. And especially if we're thinking about health inequality and intersectionality, there might be some characteristics that are very relevant that actually are not routinely collected. So really thinking about those qualitative insights and collecting input from patient and clinician can be very critical to present a complete picture. And then still on the measurement framework, there are a few things that will be really helpful for you to think about. They're a bit more of quick fire learnings here. So really thinking about having access to demographic and impact data together so that you can draw findings, having a consistent data collection or data capture, so thinking appropriate and similar coding and way of capturing the data throughout the region of interest, so if it's different sites or nationally, for example. Thinking about how you engage with the clinical and organization staff members so that you get buy-in and have the right relationship in place to help the project. And then still on that point, really thinking about what that means for the site in terms of engagement and capacity needed, both to support with some of the data collection activity, but also just to be engaged and help with some of the interpretation as well. So conscious of time, and I know we're slightly overrunning, but we really want to finish on some key takeaways. And if there's just a few things that you take from this session, those are the ones that we want you to think about. So first, really to think about embedding health equity from the start. So this cannot be an afterthought, and it needs to be part and parcel of the intervention, design, and the evaluation. And that really, for us, it's really around having a change in mindset and a culture that just includes it as a standard element. The second element is really to allow time for that initial exploration to understand and document current barriers, difference in access, experience, and outcome, and just what sort of gaps or barriers you might have throughout the project. Next one will be to encourage stakeholder participation and ensure that your stakeholders are reaching far and wide and that they are representative of the population of interest, and really think about engaging with them with humility. You will not have all of the answers, and there's a lot of elements that you cannot think about without their input. So that's also something that's very valuable. And still in a similar vein is to think about how you will account for people's lived experience throughout the project and in the intervention as well as the design of the evaluation. As we've mentioned, with some of the learnings, have an awareness of the data limitation. There are some structural bias, some missing data, some data that also lack the representation that is needed to make it impactful. So those will impact how the evaluation can be interpreted and disseminated. So being transparent and having an awareness of that will be really important. And then finally, consider if you can use mixed method approach to have a more holistic methodology, and so that you can present a more nuanced narrative and you have space for quantitative insight, but also more of those patient voices with the qualitative reporting. So this concludes more of the presentation part of the workshop. And so we still have a little bit of time for the Q&A section part of the workshop. So we'll change screen and just see if anyone has asked any questions throughout. It's loading for me. I don't think we've got a question yet. So we'll give everyone a minute just to see if there's any burning question that you would want to share. Otherwise, we do have our contact available if there's any question that you want to ask on the material or the topic seen during the workshop. Please do get in touch with us and we're happy to follow up as well. I'll give it another 30 seconds, but it feels like maybe we don't have questions today. So happy to leave it there. Thank you so much for attending. We will be in touch with the content and we hope it's been an interesting session for everyone.
Leah, we do have a question.
Amazing.
So it's regarding impact. Could you expand, please? I know we don't have mics on this, unfortunately.
Yeah, I think we've got another question. If do you know why the Black women were more likely to participate in the online course? So I guess maybe a bit of a question for you, Faye, in terms of were there any qualitative insights on?
We didn't generate too many qualitative insights around that. Unsure whether, Ben, you have any ideas. We were both on the project.
So unfortunately, that's, I suppose with any evaluation, you always think about, so what else could we have done? We were able to show quantitatively that Black women were more likely to participate. We weren't able to then sort of, I suppose, get in contact with them directly to understand why it was. We can come to a number of different assumptions, but they would be assumptions. We know that historically, Black women are less likely to want to access health services due to a variety of historical factors. But yes, that would be something that it goes on that wish list of, I really wish we could have explored that in more detail, but unfortunately we weren't able to speak directly to the participants.
Thank you, Ben. Thank you, Faye. I think we had another question, but it might be one where we wait a second just to see if the person's happy to elaborate.
We also have another one.
Yeah, so it's, could we advise on the best way to assess social impacts within qualitative research rather than financial and quantitative?
That's great. Yeah. So I'll get started, but I'm sure my colleague will have more on that in a second. So I think there's a few things to think about in terms of the research that you're looking to conduct, and some of it will be dependent on your project, but there will be elements around how big the group is, how long do you have, how much resource you have as well to conduct the resource piece that you need to think about, and also the question that you're trying to answer. And I think where you might want to go beyond financial and quantitative methods is maybe where there's a group that doesn't really engage with the services. So actually, you don't necessarily have that data of, they're not engaging, but you don't really have those reasons and that narrative to redesign your service and to have that evidence of why things need to be done a little bit differently. So this is where, it could really be transformative to use those more qualitative methods. And Ben mentioned a few at the start of the workshop in terms of conducting surveys, interview, focus group. And so, yeah, some of it will be a little bit dependent on the project, but that's probably where I would start in terms of the question you're trying to answer, some of the constraint of the project, as well as some of the key methods that you can use.
And then there's another question coming. It says, so based on the last slide where we said about encouraging stakeholder participation, the question is, what's the best way to do this from our point of view, and link to that budget for PPI and finding a balance between cost, and authentic public involvement. So it always comes down to how much do you want and how much can you afford. So broadly, when you're looking at when you're looking at a project, you need to consider that you want to do an evaluation. Then you need to think about, well, how much of your budget can you put towards the evaluation and what is going to give you the biggest impact. In terms of making sure that you get that relevant stakeholder participation, very often there are public and patient involvement groups in that area already, whether it's geographically organised by the ICS or whether it's in a particular clinical area. So I would say certainly look on basically do your research, understand sort of which groups already exist. In terms of that budget, it's always trying to make sure that there's the right balance. You can never guarantee that you're going to find sort of, I suppose, the right or the best answer. As long as you're clear on exactly how you've gone about it and you're trying your hardest, I think that's as much as realistically any of us can hope to do.
Yeah, and just on that point, and I can see there's a few more questions. So the other elements in terms of is whether you can leverage any community groups that are existing to also drive some of that engagement. And for that, I think it can really help to make it meaningful in terms of you are part of a wider initiative to engage or fix a particular problem. And I think that can also mean that you've got means to come back to that group and tell them what you've done with their input and how the time that they've given has helped to drive change. And so rather than something that can look a little bit tokenistic, it's something that is then in that long-term relationship with a particular community, and you can come back to it and continue to and you can provide them with something as well, not just take the time, if that makes sense. I think we had another question in terms of the diversity of the research team, which is a really good question. So we do have quite a diverse team. Obviously, we are quite a small company, so we can't guarantee that we get representation on the research team from all of the subgroups that are of interest for each project. But I think this is also where you want to have patient advocates as part of your PPIE so that you have that representation and that voice around the table when you're doing some of the design. So yeah, if that makes sense.
And then just a side point to pick up on that around sort of does representation impact the collection of data? So specifically from a qualitative point of view, you will get data from those who you are able to speak to and who are willing to speak to you. So it's important to consider what inbuilt bias there might be within that. So if you decide that you're only going to do your data collection electronically via email, are you then risking anybody who doesn't have access to email, or maybe there are particular population groups where they wouldn't be allowed to have their own email address, that sort of thing? So I suppose the short answer is it definitely can. The more difficult answer is it will depend on exactly which population it is you're looking at. And I suppose the best advice is really think about that population, understand what the barriers will be, and make sure that you've got methods that will do their best to overcome them.
Right. Conscious of time, I think we've pretty much come to the end of the time that we've got allocated for the workshop, but I would like to just thank everyone that attended today, and also thank you so much for your question. We are quite a big group, so we don't have the sort of camera and mic on, but it's great to just hear from you and to see your question as well. As I said, our contacts are in the presentation that we'll share, so do get in touch, and you can also find us on our socials if there's other elements that you want to discuss. But yeah, have a lovely rest of your day, and thank you for your time.